Are you looking for a more flexible work schedule, new practice environments, higher pay? Well, locumtenants.com has helped cardiologists find their dream jobs since 1995. Whether you choose an assignment locally or across the country, locumtenants.com pays for travel, housing, and even malpractice insurance. So, with nothing to lose and only experience to gain, explore local opportunities at locumtenants.com today and check out the show notes for more details.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. This is Gurleen Kaur, Cardiology Fellow at Brigham and Women's Hospital. We're so excited to bring another episode of our CNCR series where we bring cases from institutions across the U.S. I'm excited to be joined by Dr. Katie Vanchiere, Cardiology Fellow at the University of Pennsylvania, and we're here with a great group of current and budding cardiologists from Trinity Health Ann Arbor. I'm going to open it up to them to introduce themselves.
Hi everyone, my name is Akanksha and I'm a Toronto expat and current first-year fellow at the University of Michigan Health Sparrow. When not on a 24-hour call shift, I enjoy hiking, discovering new coffee shops, and spending time with friends and family. I'm interested in interventional and structural heart disease and very excited to talk about our case today.
Hey everyone, my name is Yash and I'm currently a third-year resident at Trinity Health Ann Arbor and soon to be a fourth-year chief. I enjoy anime, Formula One, reading, and baking in my free time. I'm interested in general cardiology and advanced heart failure.
Hey guys, I'm Mohammed El Nayir. I go by Mo for short. I'm a second-year IM resident at Trinity Health Ann Arbor, and aside from my passion for cardiac electrophysiology, I'm a musician. I love playing the piano and guitar.
So for today's podcast, we're taking our listeners on a boat in the Upper Peninsula on Lake Superior with some baked goods Yash has made for us and Mo providing us with some great tunes.
What a way to start the episode. This is awesome. We're excited to have you, team. Let's go through our case.
For sure. So we have a 36-year-old gentleman with a past medical history of multiple eye surgeries due to a complicated retinal detachment in his left eye following a penetrating eye injury a year ago. He had most recently undergone a vitrectomy procedure earlier the day of his presentation. He was discharged home after his outpatient procedure and he collapsed in his living room after exhibiting what his wife described to be a panic attack. EMS was called, and per the report, he was hypoxic to 56, which improved to 90s on supplemental oxygen. He was tachycardic to 126, and he was hypotensive to 77/56.
Interesting. I don't know about you guys, but I'm flashing back to my ophthalmology chapter in first aid. Yash, can you tell us a little bit about what a vitrectomy is before we dive a little bit deeper into this case?
Yeah, definitely not an ophthalmologist, but briefly, vitrectomy is a surgical procedure performed to treat retinal conditions like diabetic retinopathy, retinal detachment, or trauma-related complications. In our patient's case, he had something called proliferative vitreoretinopathy following his injury. The goal of a vitrectomy is to remove the vitreous fluid in the eye filled with debris and address issues that obstruct light from reaching the retina. During the procedure, the surgeon inserts instruments through the sclera, removes the vitreous fluid, and may also perform membrane peels. The vitreous fluid can then be replaced with silicone oil, saline, or air to stabilize the retina.
Interesting. So he was hypoxic and tachycardic at home. He collapsed and was subsequently brought to the ER. What happens next?
So his initial vitals in the ED showed a concerning pattern. His heart rate was 139, his blood pressure was 100/77, and he was tachypnic while on BiPAP 18/8. Though he was satting 100%, his non-invasive ventilatory requirements were increasing. His initial labs were notable for an ABG revealing a severe acidosis with a pH of 7.05, a PCO2 of 88, and a PaO2 of 105. His metabolic panel was notable for renal dysfunction with a creatinine of 1.55 and a bicarb of 22. He had a lactic acid of 3.7. His COVID and flu panel was otherwise negative. One of the most notable findings was his high sensitivity troponin, which is initially 31, though it rapidly peaked to 34/89 over the coming hours. On a plain radiograph, his chest x-ray showed no focal consolidation, no pleural effusion, or no pneumothorax. And an EKG showed sinus tachycardia with left axis deviation.
So at this time, with this presentation of hypoxia, tachycardia, tachypnea, I think PE is pretty high on our differential. This troponin elevation suggests some sort of myocardial injury may also be going on, raising the suspicion for a cardiac event such as a myocardial infarction.
I'm glad you mentioned that, Akanksha. We did get a CT angiogram, which revealed bilateral occlusive pulmonary emboli at the branches of both the right upper and left upper lobes. The clot burden was felt to be very mild. We discussed the case with our colleagues in interventional radiology, and they felt that the patient's clinical presentation was way out of proportion to the degree of clot burden. Now, unfortunately, right after the CT in the ER, he quickly began to tank. His vitals were dropping, his blood pressure went down. He was hypotensive despite 30 cc's per kg volume expansion and was subsequently started on norepinephrine. We also chose to empirically cover for sepsis with broad-spectrum antibiotics. He was admitted to MACU for undifferentiated shock at the time. Yash, do you mind telling us what happened next?
Yeah, so unfortunately, shortly after arrival to the unit, he rapidly deteriorated further and experienced a PEA arrest. He was intubated during the code, and ROSC was achieved after 4 rounds of CPR, receiving 3 pushes of epinephrine as well as 2 amps of bicarb, with a downtime of approximately 10 minutes. Also, given his filling defects noted on the CTA imaging, he was also given a dose of alteplase during the code.
So the patient was already quite critically sick to begin with, and he deteriorated pretty quickly as well. When considering the causes of PEA arrest, I think it's always important to come back to our reversible and treatable causes, our H's and T's. Now, it sounds like he deteriorated pretty quickly immediately after the vitrectomy. Could this embolism have been linked to the procedure?
Yeah, actually, it's possible. So remember when we were discussing the vitrectomy, there is a key step where the surgeon removes the debris-filled vitreous so that it can be replaced. In our patient's case, the agent that was used to stabilize the retina was air. We later suspected that his embolic burden was actually the result of air emboli suffered from during his procedure, but more on that later.
I don't think I've seen a handful of air embolism cases so far in my career. Do you mind running through the management of air embolism, Yash?
Yeah, definitely. It's not something that we see every day. So on the procedural side, the goal is number one, to stop further air entry, and number two, adjust the patient's position. For instance, placing the patient in reverse Trendelenburg position for lower body procedures, or placing the patient in the left lateral decubitus position, something called Durant's maneuver, to trap air in the RV, preventing it from entering pulmonary circulation. Otherwise, management with 100% oxygen is typically our first step. This helps with tissue oxygenation and helps speed up nitrogen washout. Hyperbaric oxygen therapy can also help reduce bubble size, especially for cerebral air embolism, those best if initiated within the first 6 hours of incident. Although delayed hyperbaric O2 can offer benefits, the evidence is mixed. Some patients like ours who suffer major cardiovascular collapse would require hemodynamic support in the form of IV fluids, inotropes, pressors. Lastly, in some instances, aspiration can be considered. There's a special catheter called the Bunegan-Albin catheter that I found. It has previously been shown to have some promise for aspiration, though the initial studies were done in animal models.
So, Yash, what I'm hearing is that prevention really is key and oxygen, oxygen, oxygen. Of course, if there's a skilled operator and an appropriate catheter is available, then aspiration should be considered as well. So, let's backtrack a little bit to our patient. What exactly happened after ROSC was achieved?
He was very sick. He continued to have escalating pressure requirements throughout the night and ended up on a total of 4 different agents. Despite the suspicion of air embolism because of his hemodynamic instability, hyperbaric O2 therapy was not attempted. Early in the morning, he underwent an urgent echocardiogram that showed a left ventricular ejection fraction of 65%, as well as notably systolic flattening of the interventricular septum, which is consistent with RV pressure overload, a severely enlarged RV with severely reduced systolic function.
At this point, we can see that our patient is in shock from his PE, which is contributing to right heart failure as confirmed by the echocardiogram. Mo, can you talk us through the diagnostic approach to right heart failure in general?
Absolutely. So, while physical exam, ECG, biomarkers, and CT imaging, they all play a role in assessing RV failure, the diagnosis is mostly made by invasive hemodynamic monitoring or PA catheter. Echocardiography also does have good value. On exam, what you'd normally see, or the classic triad for acute RV failure, is hypotension, elevated jugular venous pressure, and clear lung fields. This is a very specific triad for acute RV failure, but it's not always the most sensitive. Other physical exam findings could be a left parasternal heave, a loud P2, a right-sided S3, and in chronic forms of RV failure, peripheral edema. When it comes to biomarkers, there isn't really a biomarker that's specific to the RV, but an elevated NT-proBNP or BNP kind of reflects the same phenomenon of increased filling pressures. Hyponatremia could also ensue from volume overload, and signs of central venous congestion like an elevated creatinine and cardiorenal syndrome as well as LFT elevations as a sign of congestive hepatopathy. All these signs can point us into the right direction. Now, when you get a CT, there are a few findings that are consistent with right-sided strain or RV strain, and that's the RV to LV ratio. And if that ratio is greater than zero point 0.9, it has been associated with worse outcomes, especially in people with pulmonary embolism. Other findings that radiologists are good at picking up is contrast reflux into the inferior vena cava and hepatic veins. All these are different signs of right heart strain. Unfortunately, a CT might not always be feasible. Your patient needs to have some degree of hemodynamic stability to go for a CT. But what is readily accessible and very user friendly and doesn't really need that much training is bedside point of care ultrasonography or POCUS. And we use it all the time in our MICU.
Absolutely, Mo. POCUS is a great tool which can provide us with signs suggestive of pressure overload, such as septal flattening. I wonder if our cardiology fellow can tell us a little bit more about specific echo features to look out for when assessing RV function in general.
Yeah, for sure. So, some of the parameters that we can look at that help us evaluate RV function. Well, first of all, there's TAPSE, which measures the lateral tricuspid annulus's movement during systole. A TAPSE value of anything below 1.6 is generally associated with a poor prognosis. We can also look at the right ventricular outflow tract acceleration time. This is usually measured via pulse wave Doppler, and an acceleration time of less than 100 milliseconds is considered abnormal, with values less than 60 milliseconds indicating a worse prognosis. The TR jet velocity also helps us estimate pulmonary systolic pressures and can provide some prognostic information. Mo, you mentioned looking at the IVC. Well, it's useful in estimating right atrial pressures and guiding volume resuscitation, although this does lack prognostic significance. In terms of POCUS, we can always try to obtain a clear four-chamber view and look for signs of right ventricular pressure overload, or the McConnell sign. This is where there's RV free wall akinesis with apical sparing. Of course, if we get a peristernal short axis view, we can also look for the septal D sign, where the interventricular septum actually shifts towards the left ventricle. And so what we see is a D shaped septum. Depending on which phase of the cardiac cycle we see the D shape in, it's consistent with either volume overload, pressure overload, or both.
That's really great. And I always like looking at the 2023 EFPPE guidelines. They have a really great graphic that shows the different echo findings of RV failure and NPE. So we can definitely include that in our show notes for people to have a visual representation of the findings that you just walked us through, Akanksha.
Awesome. Thanks for that. So, coming back to our patient, summarizing the information that we have so far, he's a 36-year-old guy who underwent a vitrectomy, an outpatient procedure, and suffered a PEA arrest with ROSC after approximately 10 minutes due to a suspected PE. We know that our patient has been requiring increasing doses of vasopressors with echocardiographic evidence of reduced RV function. Our patient's clot burden, however, was read as mild on the CT. How do we put all this together?
Well, yeah, it just really goes to tell you how truly complex RV physiology is. And the RV differs from the LV in terms of structure as well as function. It has a very thin series of myofibril layered longitudinally, and it's only 3 millimeters in diameter compared to the LV, which is around 11 millimeters. Now, that really primes the RV to handle acute or sudden volume changes, but it tolerates pressure changes very, very poorly. Now, the RV ejects the same stroke volume as the LV, but against a much lower resistance system, which is the pulmonary vasculature. And this results in an RV stroke work, which is only 1/4 of that of the LV. Hence, you don't really need a thick RV. In patients without pulmonary disease, the RV struggles to generate pressures above 40 millimeters of mercury during systole. And whenever PVR rises, RV stroke volume acutely drops, and the RV compensates in the only way it can because of its thin chamber, and it dilates. Now, when that RV dilates, contractility and cardiac output just take a dive. And this often leads to functional tricuspid regurgitation because the tricuspid valve apparatus starts to dilate. And RV dilatation, it also forces, like Akanksha was saying, it forces that interventricular septum into the left ventricle, and that impairs LV filling. And this phenomenon is known as interventricular dependence. Another really important point to keep in mind is the RV is perfused in both systole as well as diastole. And the main driver of your coronary perfusion is the gradient between the coronary artery pressure and your RV transmural pressures. And in our patient, his RV pressures were significantly high and he had a drop in his systemic pressure. And this leads to RV ischemia and further exacerbates RV dysfunction and ultimately can easily lead to hemodynamic collapse.
Wow, that was a lot of information. So, to summarize the key points, the RV is more adept at handling volume changes, but struggles with sudden pressure changes. As the RV dilates, it loses its ability to pump as effectively.
Yeah, exactly. In our patient, he had an acute PE, which acutely raised the pulmonary vascular resistance and in turn increased the right ventricular afterload. This was driven by both the clot burden as well as certain neurohormonal hypoxic driven feedback mechanisms. This caused an abrupt right ventricular increase in the afterload, reduced his stroke volume, and the right ventricle really in turn struggles to maintain adequate output. This just creates a negative feedback loop. Worsening RV dysfunction makes the LV performance worse, and vice versa. This really results in a sort of right ventricular death spiral of sorts.
Interesting. So, guys, let's go through a systematic approach to the definitive diagnosis and management of these complex patients.
For sure. So, last we left off, we know our patient is in shock based off of his increasing vasopressor requirements, and we suspect acute right ventricular failure. Now, he's on 4 vasopressors at this point. He's maxed out on norepinephrine, he's on epinephrine, phenylephrine, and even angiotensin 2 was added. At this point, we're in a pretty dire situation and need more information in the form of invasive hemodynamics. A right heart cath is probably the best next step. Mo, can you walk us through that a little bit?
Absolutely. So our patient actually underwent both a left and a right heart cath, which we call bicath. I don't know if that's the same term used everywhere else, but his left heart cath showed angiographically normal coronaries and his LV EDP was only 14. Can I get a drum roll for the right heart cath? Thank you. His RA pressure was 15, PA pressure was 31 over 22. Pulmonary capillary wedge pressure was 31 over 28 with a mean of 29. SVR was 1700 and cardiac index was 2.0 on 4 pressors.
Oh man. So, when looking at these right heart cath numbers, there are a few important values to consider. These include the ratio of the right atrial pressure to the pulmonary capillary wedge pressure. Now, historically, a value of more than 0.86 has been associated with right heart failure. What we use more often in clinical practice is something called the PAPI, or the Pulmonary Artery Pulsatility Index, which is the ratio of the pulmonary artery pulse pressure to the right atrial pressure, which has been shown to be a reliable marker of right heart failure. Another important measurement is cardiac output, which should be estimated by the Fick method using oxygen consumption as opposed to thermodilution, which can be inaccurate in certain patients, such as those with significant TR.
Yeah, so for our patient, the PAPI was calculated at zero point 0.6, which is indicative of acute RV failure, and his cardiac index was 2. For reference for our listeners, a normal PAPI is something greater than 1.85, with lower values associated with RV failure in different clinical settings. In the context of an acute MI or an acute inferior MI, a value less than zero point 0.9 is associated with increased in-hospital mortality. And a normal cardiac index, depending on who you ask, is anywhere between 2.5 and 4.2. Shout out to another CardioNerds episode on interpreting invasive hemodynamics with Dr. Noshin Riza, episode 172.
So now we have a definitive diagnosis of acute right ventricular failure in our patient, which in itself really presents some unique challenges. I think taking a systematic approach, like you were asking about earlier, Yash, is really important. The way that I've learned to manage these patients is via a 3-pronged approach. 1, we have to optimize the preload. 2, we have to reduce the afterload. And 3, we really have to support the cardiac output.
I'm glad you mentioned optimizing preload first. This is something that can be pretty tough and requires accurate assessment of the overall clinical picture. RV preload requirements can vary depending on whether the afterload is normal or increased. For example, if the afterload is normal, RV and diastolic pressure often would need to be higher to maintain an adequate cardiac output. However, if it occurs in the setting of an increased afterload, excessive volume loading can actually do harm. It can displace the septum, like you guys were talking about earlier. When we think about what happened to our patient when he presented with persistent hypotension, he was initially aggressively fluid resuscitated in the ED and then continued to require multiple vasopressors. What we see now while in the cath lab is his right heart cath is showing an elevated wedge pressure. This is a great example of how we have to be careful to maintain adequate cardiac output without exacerbating venous congestion. Interestingly, while the data isn't great, there's some small non-randomized studies that suggest diuresis may also improve markers of RV strain and hemodynamics in intermediate risk PE. But again, preload is just one part of the equation. Mo, can you go over afterload for us?
Yeah, you're asking for too much now, Yash. So the second part of the equation, afterload reduction. The first thing that we look at is there any reversible factor that's playing a role in increasing your pulmonary vascular resistance? And this includes things like hypercapnia, acidemia, alveolar hypoxia. Ideally, you want to keep these people above an SaO2 of 92%, and you want to continuously get blood gases and adjust your ventilator to optimize lung volume and to maintain a normal pH and PCO2. There have been some studies that suggest inhaled nitric oxide is useful. It's a very potent pulmonary vasodilator, and it only selectively improves perfusion to well-ventilated lung, being the keyword. And that improves oxygenation and helps unloading the failing RV. It has been shown to improve RV ejection fraction and pulmonary hemodynamics in patients in acute RV failure. Now, for the third part of the equation, Yash, can you tell us what we can do to support the failing RV?
Yeah, so there are a number of options to help support our cardiac output in a failing RV, several of which were already used for our patient. The initial vasopressor for him is one of everyone's favorite, norepinephrine or levofed. Though it's primarily an alpha 1 agonist, it also has some beta 1 stimulation. It helps improve systemic blood pressure and also has some benefits in maintaining RV-PA coupling. Another option, though not as preferred, is phenylephrine, a pure alpha 1 agonist. It does not improve RV contractility, and it actually could contribute to increased pulmonary vascular resistance. Though sometimes in the cases of acute hypotension, it does get initiated. Now, when it comes to inotropes, our goal is to improve RV contractility while minimizing adverse effects. One of the most commonly used options is dobutamine, a beta 1 agonist that improves myocardial contractility and helps improve RV-PA coupling, though it can cause vasodilation at higher doses. Milrinone, a phosphodiesterase 3 inhibitor that enhances inotropy, can also contribute to pulmonary vasodilation. It's particularly useful in BIV failure and post-transplant patients. In general, dobutamine can be preferred in acute RV failure unless hypotension is a significant concern, in which case norepinephrine might be preferred for that extra alpha 1 activity. And in cases of pulmonary hypertension, milrinone can be preferred because of that vasodilatory effect. To our knowledge, there aren't really any head-to-head studies comparing which one is optimal in acute RV failure. I think it just depends on the clinical situation.
Our patient was already on multiple vasopressors, though. So I think at this point, we really have to consider how can we escalate care further. And I think at this point, we have to look into mechanical support devices.
I'm really, really glad you mentioned that. What actually happened is when he was in the cath lab getting his left and right heart cath, he went into PEA arrest again, but this time it was fairly brief. CPR was initiated right away, and ROSC was achieved when an Impella RP was deployed.
Yeah, after that, he returned back up to the CCU where he's closely monitored and managed with an indwelling swan. Over the upcoming 48 hours, his pressor requirements dramatically improved, and he was weaned off of all pressors by day 3, and he was also able to be weaned off of the Impella. His swan numbers on day 3 off of all pressors after the Impella removal included a cardiac index of 2.99 and a PAPI greater than 0.9. It was definitely cool to see him recover so quickly after the Impella was put in. Mo, can you review some of the indications for mechanical circulatory support for us?
Yeah, it is pretty cool, isn't it? Now, according to current AHA guidelines for RV failure, which was published back in 2017, short-term MCS or mechanical circulatory support should be considered in patients with cardiogenic shock. And in general, it serves as a bridge, either a bridge to a decision, a bridge to recovery, or it has to be a bridge to something until the underlying cause of cardiogenic shock is resolved. When we consider using MCS, we do look for signs of relative hypoperfusion along with hemodynamic features that we did describe earlier in the case. That's just RV failure. Now, one key point to keep in mind is when acute left-sided mechanical circulatory support reveals signs of RV failure, it's really important to differentiate whether the RV failure is intrinsic or caused by persistently elevated RV afterload. And this is due to inadequate LV support. And this distinction is really crucial because it does guide our treatment decision. Now, the primary goal for percutaneous MCS is to bypass. It's to help that failing RV recover and give it time to heal. And at the same time, improves hemodynamics and gives us time to figure out what's going on to optimize our patient and to help the RV recover. Yash, do you want to go over the types of support and what we did for our patient right here?
Yeah, so there are three kind of basic models or categories of RV mechanical support. The first is venous arterial extracorporeal membranous oxygenation, also known as VA ECMO, which draws blood from central venous circulation, passes it through an oxygenator, and delivers it back into the arterial system with a centrifugal pump. This device effectively reduces both RV preload and afterload while substantially increasing systemic afterload and tissue perfusion. Specifically in the cases of PE, recent guidelines from the ESC state that VA ECMO may be considered in high risk PE in combination with surgical embolectomy or catheter directed treatment in refractory cardiogenic shock or cardiac arrest. Next up, there's an RA to PA extracorporeal pump. An example of this could be a surgical RVAD, where blood can be removed from the RA and delivered into the PA using a centrifugal pump. An oxygenator may be added if needed. Blood is removed using two large bore cannulas or a specially designed catheter with an intake bore and an output bore. RV preload is effectively reduced while increasing mean PA pressure and LV preload, letting the RV recover. Lastly, an axial flow device. This has an intake in the RA and an output in the PA. Though this device does not allow for an oxygenator, they've been shown to improve hemodynamics, though we have to be careful when using these devices to treat RV failure and monitor for presence of concomitant LV failure, as the increased cardiac output can further exacerbate LV function. As we know in our patient, he got an axial flow device or an RP Impella. This is a 22 French impeller mounted on an 11 French catheter that delivers blood from the RA into the PA. Can you tell us a little bit more about the data supporting this?
Yeah, so there is a nice trial that was published back in 2014, the Recover Right trial. It was a prospective multi-center single-arm study that really basically assessed the utility of Impella RP device for medically refractory RV failure. And although it had 12 patients in the acute MI arm and 18 patients after cardiac surgery, what was seen throughout these patients is deployment of Impella RP immediately resulted in a drop in central venous pressure and an improved cardiac index, allowing rapid weaning of inotropes and pressor support. And that is actually what we saw in our patient. So, Yash, let's circle back and kind of recap where we were.
Yeah, so to wrap up our patient's case, when we last saw him, he was off pressors and weaned off the Impella support. Unfortunately, his clinical course was complicated by anoxic encephalopathy, as he was noted to have multiple cerebral emboli noted on MRI imaging. However, by day 10, the patient was following commands, he passed a spontaneous awakening breathing trial, and he was successfully extubated. He also suffered from acute renal failure due to his shock and was briefly requiring runs of CRRT while in the unit, and then was eventually transitioned to HD. By hospital day 22, he made such significant improvements that he was actually able to be transferred to IPR. Most recently, the patient is nearly back to his baseline. He's off hemodialysis and he actually goes to the gym 5 times a week.
Wow, what an incredible recovery, guys. I think it's cases like this that really make medicine just so gratifying. I guess the next question is, what can we really take away from this case? I think, first of all, it's a great example of the complexities of right heart failure in the setting of PE. While the embolic burden in this case was actually considered mild, the right heart response was quite severe. It's a reminder that the body's cardiovascular system is highly adaptive, and under enough strain, even mild to moderate insults may push it past its limit. Another important takeaway is really the role of mechanical support. In this case, the use of the Impella device provided critical right ventricular support while other therapies were optimized. The success of this approach, alongside aggressive fluid management, renal support, and airway protection, I think it really underscores the complexity of managing such critical cases such as this.
Yash, Akanksha, it's been so great to hang out with you and learn about RV failure. I think RV always has been thought about as the forgotten ventricle, but the RV is always humbling and always fascinating. And I think the key to management of these patients is also timely recognition, because we know from data from the Cardiogenic Shock Working Group, as well as the Critical Care Cardiology Trials Network, that the presence of RV failure really increases the mortality risk when we think about all stages of SCI cardiogenic shock. So it's really this timely recognition of decompensation, such as what you outlined in this case about how to recognize it on POCUS and hemodynamics and clinical assessment, is really important in helping improve outcomes in this population.
This really has been an incredible case of an extremely sick patient who made an impressive recovery. Y'all have done a great job highlighting the unique anatomy and pathophysiology of the RV, the importance of multimodality assessment in diagnosing RV failure, including the physical exam, echocardiography, and invasive hemodynamics. You've also highlighted the importance of considering RV preload, afterload, and inotropic support, and the options for temporary mechanical support to support end organ perfusion and allow for reversal of the etiology of RV failure. This case really has hit all the highlights, and we really appreciate you all joining us today to talk about the case and to talk about the things you learned from this patient. So thank you so much for joining us. This has been an incredible learning opportunity.
Thank you, guys. Thank you so much for having us.
Thank you, guys. This has been great.
Hope we can do this again sometime.
And now for the expert commentary and review segment of the episode, I'd like to introduce Dr. Tanmay Swadia, interventional cardiologist and cath lab director at Trinity Health Livonia. Dr. Swadia trained at Henry Ford in Michigan and currently practices with the Michigan Heart Group. He's a member of the SHOCK team and a beloved CCU attending, known for his outstanding teaching, stories, and clinical acumen. We're honored to have him share his insights and expertise on this case.
Hi, my name is Tanmay Swadia. I'm an interventional cardiologist with Michigan Heart. I'm the cath lab director at St. Mary Mercy Hospital and also part of the SHOCK team at St. Joe's in Ann Arbor. This was a really nice job by you guys, Akanksha, Yash, Mo. I got to give you credit for such an amazing presentation. I remember this case like it was yesterday, although it has been a couple of years now. This was like you said, a young gentleman, 36-year-old, came in with air embolism to his lungs after a vitrectomy surgery. Basically, we were called in when he was in frank shock, had multiple rounds of CPR. We got an echo and it clearly showed that the RV was dilated and really just akinetic, not doing anything. He was on multiple pressors at that point, quite critically sick. So at that point, the question asked to us was, whether or not we can provide any kind of hemodynamic support. Obviously, we felt at the time that the quickest thing to offer him would be an Impella RP. So we brought him down to the cath lab and we just shot the cornea angios just to make sure there was no coronary artery disease. And there was no disease. His EDP was only 14, which again makes sense because, this was predominantly an RV issue. So then we proceeded with the right heart cath, which showed elevated RV filling pressures. The PAPI, as you mentioned, was low at 0.6. PAPI greater than 0.9 is considered to be adequate, and certainly less than 0.9 is indicative of RV shock. So we got a PAPI of 0.6. At that point, as we were doing all this, he goes into PEA arrest again, probably because his RV isn't really functioning at all. So there's no forward flow to the left side, and he lost his pulses. So we started CPR. Thankfully, it was during the daytime, and we had plenty of help available in the cath lab. So we started CPR. As CPR was being performed, we already had venous access in place in the right femoral vein. So we decided to just go ahead and place the Impella RP at the time while CPR was ongoing. So we upsized for the Impella sheath. We placed the Impella RP. And lo and behold, as soon as the Impella RP goes in, we turn it on. We get beautiful pulsatility on his arterial line. We got pulses back and really quite impressive pulsatile flow. Basically, what had happened is the RV Impella or the Impella RP took over for the right ventricle. And as a result, the left side started getting filled again and we had pulsatile flow. So that was quite gratifying to see. That it still remained critical. I mean, we hadn't weaned any pressors yet because, the pump had just gone in. But deep inside, I did feel that there was hope for this gentleman. At this point, he goes up to the medical ICU, and as Yash and Mo sort of pointed out, he actually did really well. His hemodynamics started improving promptly. He came off pressors over the course of next couple of days. Unfortunately, his MRI of the brain showed significant anoxic encephalopathy, and we were quite worried about it. Now, mind you, this is a 36-year-old, and we know that young people are quite resilient. So that was the only guarded part about this as he recovered. So he had a long session of inpatient rehab. Subsequently, I saw him in the clinic a few months later, and he was doing really well. He had started to play puzzles with his kids and seemed like life was going to be okay. Now, more recently, I've heard back from him, and it looks like he's back working full-time as his duty as a vice president of a pretty big company, doing really, really successfully well. So this has been quite a rewarding case for us. Somebody who was actively undergoing CPR, multiple pressors, massive PE, felt to be, because it was predominantly an air embolism in the distal vessels, he was not felt to be a good candidate for TPA or catheter-based treatments. And the only option we had for him was hemodynamic support. And as soon as he got it, he did really well. So this case sort of highlights some of the advancements we've had in treating cardiogenic shock, especially RV shock. We know over the years that Despite various advances, the mortality from cardiogenic shock has remained quite flat at around 50%. But I do think this is going to be quite a game changer. We know we have data coming out that, pressors are great to buy you time, but they're not going to be the definitive treatment for shock. There's plenty of papers out there that say that your mortality actually goes up as you increase the number of pressors. So there's a paper out of Detroit and some of the other centers that show that, if you're on 1 pressor versus 2 pressors, your mortality actually goes up. And similarly, if you're on 3 pressors, 4 pressors, the mortality keeps going up. So pressors and inotropes are great, but they're not necessarily shown to improve survival. The reasoning behind this is that, while you're getting the ventricle to work harder, but this is at a cost. It increases your oxygen consumption and sometimes leads to arrhythmias and other things that actually raise your mortality. Mechanical support is going to be the future. There are plenty of studies that are ongoing. There's one study that you referred to, Mo, was the Recover Right. And I used to be a fellow at Henry Ford when we did one of the cases that was part of that study. And you could tell that this device definitely had potential. There's been design changes since then, and now the Impella RP is actually designed to be put in from the right IJ, so internal jugular vein. So these patients, while they're in shock, once they have the pump put in, they can actually sit up and kind of wait for their RV to get better, which is way better than laying flat from a femoral approach. There is plenty of case reports coming out that this is going to be quite the game changer, especially in RV shock when it's in the setting of RV infarct or PE. And I think this is going to be the future. We've now had quite a few of these cases where these massive PE patients come in, they're in shock or they've arrested and they've had CPR or multiple pressors and it all looks dull and gloom. But, once you treat them appropriately with either TPA or catheter-based treatments such as thrombectomy, if the shock does not improve and they still remain sick, what we've started now doing is using RV support with the Impella RP device quite routinely. Now, we've had devices that actually can be put in through the neck, as I said earlier. What we've typically noticed is that these patients turn around pretty quickly, and most of our cases usually come off pressors within the next 24 hours. In about 48 hours of support is usually enough for these patients. Rarely we've gone into day 3 and provided maybe around 72 hours of support. But what we've noticed is most of these cases, the renal function gets better, the LFTs get better. As long as you've started the support promptly, these patients actually do really well and the shock gets better, and most of these patients have survived. We're currently writing up a case series to kind of show what our data is, and I can tell you this, the data looks really promising. As we sort of evolve in the way we treat cardiogenic shock, I think the reliance is going to be more on mechanical circulatory support. And the question is, which is the best circulatory support device? I think this one that can be placed percutaneously and promptly and quickly would be the answer. Great job, everybody. And if there's anything else you need from me, let me know. Thank you.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Chu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.